Can you see the slides?
Yes, yes.
Yes.
Okay.
That we can now see clearly.
Okay, that's fine. So sorry for the delay. We had the wrong Zoom account, and please tell all your colleagues that whoever doesn't have a clear name will be put in a waiting room, because we've had some instances where people are really ill-mannered. So now I want to control such people. So this afternoon, I'm going to talk about an important aspect of immunology, which is immunological tolerance and autoimmunity. So I will, of course, begin by teaching you about tolerance. So how does our body ensure that we do not self-react? Because as you can remember, we have disorders of the immune system where you have either autoimmunity, immune deficiency, and then hypersensitivity. I'm sure you've already talked about hypersensitivity, and someone covered immune deficiencies. So now I'm going to cover autoimmunity, which is one of the shortest aspects of immunological problems. But I'll start by covering tolerance so that then we can tell what happens when someone becomes intolerant to their own antigens. So immunological tolerance is actually a state in which an individual is incapable of developing an immune response to a specific antigen. And in this case, if you talk about self-tolerance, then the body is incapable of developing immune response to their specific antigens. So you cannot destroy your own red blood cells, you cannot destroy your own tissues, because the body has mechanisms in place that stop this from happening. So if this fails, then you end up getting autoimmunity. So this tolerance is classified into two. We have the central tolerance, which occurs in the thymus and in the bone marrow, and then the peripheral tolerance, which occurs in tissues. And this is important, and you must be able to tell the differences between these two, between self-tolerance and peripheral tolerance. So central tolerance really refers to deletion of self-reactive either B or T lymphocytes that would, in this case, be capable of destroying their the body's own tissues. So if in the development of a cell, the cell is found to have a capacity, okay, to destroy the body's own antigens, that cell has to be destroyed. So if this occurs either in the thymus for T cells or in the bone marrow for B cells, then this is called central tolerance. Okay, so we have this deletion of self-reactive B or T cells that can occur during their maturation, and this occurs in the lymphoid organs. Then we have this pictorial that you're looking at there. We're looking at the bone marrow. So in the bone marrow, you have these pro-T cells, so the progenitor T cells. Now we sometimes have these self-reactive clones. So destruction of these self-reactive clones within the bone marrow is what we call central tolerance. Okay, because if you do not kill these self-reactive T cells, if these clones proliferate and they go into your peripheral tissues, then you end up getting autoimmune conditions. Now, normally speaking, our T cells bear receptors for these. Our T cells bear receptors for T cells bear receptors, and these receptors are usually the ones that are going to induce the cell to be either destroyed or to remain. Now, if this T cell bears a receptor for a self-antigen, then it means that if you do not destroy this cell, or if this cell goes into blood, it goes into your peripheral circulation, this cell is going to end up causing autoimmunity. So in central tolerance, the T cells that bear those receptors, okay, will undergo apoptosis within the thymus, and they will end up being destroyed so that they do not mature into clones that end up proliferating into our central, into our tissues. And that is the gist of this central tolerance. So during development, many autologous protein antigens are processed. So you can imagine that in your thymus, there are so many antigens. So these are normally presented complexed by our self MHC. I'm sure you learned about MHC because MHC is very important. So in this case, these antigens have to be complexed with the self MHC, meaning that they are self antigens. So if these are then presented to these proliferative T cells, the moment any T cell shows capacity to destroy that type of antigen, then instead of the antigen being destroyed, it is the T cell that undergoes deletion. That is the so-called central tolerance. Okay? So development T cells which have affinity for those receptors are going to be negatively selected. So it's literally very simple. You have antigens that are being presented, and they are presented complexed by self-MHC. Because as remember, the MHC are so important in telling that this is auto, this is self, and this is non-self. So if you have a self-MHC presented in conjunction with our antigen, the body's antigen, once that complex is presented to the T cells, the moment a T cell reacts or expresses capacity to destroy this complex, then the body will recognize that this T cell has a capacity to become an auto T cell. So it is destroyed. If this occurs in the thymus or the bone marrow, that is the gist of the central tolerance. So the same thing happens. We can also have this clone deletion of T cells. So this can also affect the B cells. Okay. Now, when these developing B cells encounter a membrane-bound antigen, so imagine you have an antigen in your bone marrow, the normal antigen. If these B cells encounter this antigen and they try to react, so they try to make antibodies against this antigen. Once they do that, then they are going to be destroyed through self-tolerance is that it ensures that no self-antigen recognizing cell present in either the thymus or the bone marrow will slip into the periphery. And that is so important. But of course, at times that system fails. Okay? Even when the body tries to put in this mechanism, it fails. Okay? And if it fails, then that is when we end up with autoimmune disorders. But of course, if the central tolerance fails, in other words, we have these autoreactive T cells escaping from the thymus and from the bone marrow into blood, we have another mechanism that will still ensure that these cells are destroyed. This is where we have the peripheral tolerance. So this peripheral tolerance ensures that T cells that escape the intrathymic negative selection, okay, are destroyed within the peripheral tissues. Because if these don't get destroyed, you still end up getting autoimmune conditions. So you have three backup mechanisms that will silence these potentially autoreactive T cells. What are these mechanisms? The first one is through clonal deletion by activation of programmed cell death. The second one is clonal energy. So we can either delete by apoptosis, or we can make these cells to be inactive, to be anergic, to be unresponsive. Or we can have these cells being destroyed through T cells, the so-called peripheral suppression by T cells. So clonal deletion by activation and also by induced cell death. How does this And that is what I'm going to try to explain to you. So this mechanism is put in place to prevent uncontrolled T cell activation during the normal immune response. Okay, and this normally involves gradual death. There's something that is called the FAS. That FAS refers to the cell surface receptor. So these cells, when they come from the thymus and the bone marrow, they have a specific receptor that induces apoptosis, and this is the so-called cell surface receptor. Now, when a cell escapes from the thymus and from the bone marrow, then the expression of these cell receptor increases, and they end up combining with the antigens it finds within the periphery. These, of course, antigens will be presenting the FAS. Okay, so the moment you have this FAS antigen and the FAS ligand being recognized, it means that these cells are going to be auto-deleted. Okay. Now, the expression of these cell surface death receptors, also the so-called CD95, is upregulated in these antigen-activated T cells. In other words, the moment you find a T cell that is autoreactive, once it reaches into the periphery, its expression of CD95 increases so that the cell automatically undergoes apoptosis. Now, engagement of these cell surface death receptors by the cell surface ligand, which is co-expressed on the activated T cells, will dampen the immune response, and this will induce apoptosis of the activated T cell. Okay? So normally speaking, self-antigens are usually abundant in the peripheral tissues. And because of this, we tend to have persistent stimulation of these self-antigen specific T cells. And that stimulation will ensure that these are regularly eliminated through the FAS-mediated apoptosis. Like I said, FAS is cell surface death receptor. So the second mechanism is the clonal energy. Now, in clonal energy, we have a prolonged or irreversible functional inactivation of lymphocytes. And this is induced by a counter with antigens under certain conditions. So in this case, you have a group of T cells that are rendered inactive. And they're rendered inactive because they are auto-reactive. How does this occur? If you remember T cell activation is a two-system process. Okay, we normally need two signals. The first signal is usually the recognition of the peptide, and this is usually in association with the MHC molecule. Then the second signal is the costimulatory signal. Now, in this case, if you can imagine, the first signal is going to be presentation of a set of antigen, meaning that it is going to be an antigen that is complex to the self MHC molecule on the surface of an antigen presenting cell. Once that happens, then the second signal is going to be the costimulatory signal, which is still provided by the antigen presenting cell. Now, if this was a foreign antigen, the costimulatory signal would induce activation of the T lymphocyte because the MHC that is being presented with is for a foreign antigen. But in this case, because the MHC is for self, the costimulatory signal will not be for destruction. Instead, the costimulatory signal will induce this cell to become anergic. Okay, so in this case, we find that the second signal, in this case, of course, it is usually the CD28, will be a negative signal. And negative signal in this case means that the cell will not respond to this stimulation. And that is the difference between the positive stimulation and the negative stimulation. In a positive stimulation, you have a foreign antigen, which induces an MHC production. So the MHC that is complex to a foreign antigen will induce a co-stimulatory molecule, which will produce a positive signal. Positive signaling means that the T lymphocyte will become activated, and then it will increase. It will start to undergo replication, and then you end up with destruction of these molecules. But in this case, the T lymphocyte will not respond because it is recognizing the MHC as being normal. So such a cell then fails to be activated, even if the relevant antigen is presented by component antigen presenting cells. And we have a co-stimulation. So the failure of this T cell to respond is what we call anergy. And anergy is because the co-stimulation is by CD28. So CD28 induces anergy, and this only happens if we have a safe MHC. The third one is the peripheral stimulation of T cells. Now in this, we have the suppressor T cells playing a role, okay? So if we have an autoreactive T cell, then our suppressor T cells are capable of recognizing these as abnormal cells, and they will instead remove them. They will instead attack and destroy them. Okay? The molecular mechanisms behind this are not well understood, but at least we know that our suppressor T cells are able to recognize autoreactive T cells and remove them from circulation. That is the so-called peripheral stimulation of T cells. Now, tolerance is very, very important in preventing autoimmune diseases, okay? And if this fails, then you end up getting autoimmune disorders. And tolerance is induced in fetal life, although it can also be induced in adulthood, but it tends to be induced very, 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 very early on in fetal life. Because as you can imagine, as the fetus is developing, all the cells are prepotent. Therefore, the body sorry, something So now next we're going to look briefly at autoimmunity. Can you see my slides?
Yes, we can.
Yes, sir.
So now so the first part
Yes.
was looking at tolerance, and we've said we have two types of tolerance. We have central tolerance, which is induced in both the bone marrow and the thymus. And we said this is important in preventing autoreactive T cells and B cells from entering into circulation. And this is done by deletion of all those B or T cells that express, that are able to recognize self-antigens. And then the peripheral tolerance occurs in tissues, and this is to ensure that all those autoreactive T cells that escaped central tolerance are eradicated within the periphery. And we said there are normally three mechanisms. You have chronodeletion, clonal energy, and then the peripheral suppression by T cells. Now, even if all these mechanisms are put in place, at times there is a failure, and then we end up getting these autoreactive T or B cells. And this is where we end up getting autoimmune disorders. So what are these autoimmune disorders? So autoimmune disorders literally imply that there are these conditions that are as a result of loss of self-tolerance, okay? And in this case, our immune system will react against our own antigens. So when someone has an autoimmune disorder, it means that they have antibodies that have failed to recognize the body's tissues as their own, and therefore they are inducing an immunological reaction. What are the factors that predispose individuals to these autoimmune disorders? One of them is genetics. We know that familial clustering is usually associated with the presence of certain areas. For example, if you find HLA, DR4, of course, these are MHC. So if you find presence of HLA, DR4, usually people who have this allele, HLA, DR4, are likely to suffer from rheumatoid arthritis. So you end up with people in a family where everyone in that family has rheumatoid arthritis. In addition to this, families where we have HLA-B24, these ones are likely to get ankylosing spondylitis. So I would expect you to go and read about rheumatoid arthritis and ankylosing spondylitis if you're going to understand these conditions in detail. But we know that these tend to run in families. Now, interestingly, the presence of these MHC clusters are necessary, but they are not sufficient to induce an immune and autoimmune disease, meaning that other factors beyond your genetics play a role. What are some of these other factors? One of them is the gender. Of course, gender is being either male or female, okay? Now, class 2 MHC associated conditions like rheumatoid arthritis, like Graves' disease, like systemic lupus erythematosus are very common in females, whereas class 1 associated conditions like ankylosing spondylitis and Reiter's are usually found in males. Rheumatoid arthritis
According to Mayo Clinic, an inflammatory arthritis affecting the spine and large joints
of your hands, and they become deformed. Graves' disease normally attacks the thyroid gland. Someone ends up getting proptosis, heat intolerance, weight loss, and they have a lot of energy. SLE tends to present with both systemic conditions, but also dermatological conditions. So I would expect you to read about these conditions. So rheumatoid arthritis, Graves' disease, and SLE are very common among females. It does not mean that they don't occur among males, but we know that they are very, very common among females. And it's because of estrogen. So estrogen plays a very, very big role in these gender issues. Then ankylosing spondylitis and Reiter's is very common among males. Reiter's, as remember, patients have three things. They have conjunctivitis, arthritis, and urethritis. So these are usually very common among the males. Another very important factor is the hormones. 90% of these autoimmune conditions occur in females. Reason being that they are usually associated with presence of estrogen, okay? And it's because estrogen enhances formation of antibodies against DNA. And because of this, as people become older, okay, some of these conditions improve, although some of them actually worsen as we become older. But by and large, as estrogen levels reduce, some of these autoimmune conditions improve. Environmental factors play a very, very big role, and usually these are going to be diseases and disease-causing organisms. We know from your first semester that individuals who have strep-induced tonsillitis are likely to end up getting a rheumatic fever. And the reason being that strep pyogenes has a molecular mimicry. So this molecular mimicry means that when the body makes antibodies against the antigen that is found in these organisms, these antibodies are unable to distinguish between safe and non-safe antigens. And then those antibodies will end up forming complexes that get deposited, okay? So these antibodies will destroy your heart, which explains rheumatic heart disease. But they can also destroy your kidney, causing glomerulonephritis. Coxsackie, we know that individuals who suffer from Coxsackie virus might end up getting type 1 diabetes mellitus because the antibodies that are produced by this Coxsackie will end up, unfortunately, destroying the islets of Langerhans. And when this happens, you end up with inability to produce insulin. Therefore, someone ends up getting type 1 diabetes. There are other conditions which I'll be telling you about soon. Age. Some autoimmune conditions worsen with age, okay? Some of these worsen with age. And because age is associated with the deposition of so many other antigens, as we age, our cells start to leak, and they tend to leak out DNA, which we've seen tends to increase autoimmune conditions. So what you're looking at there is a table that looks at organisms and the autoimmune conditions associated with them. Streptococcus pyogenes is associated with rheumatic fever, and as you remember, it is because of the M protein found within these organisms that resembles the C carbohydrates. So when we form antibodies against these streptococcus pyogenes, these antibodies also damage the valves, so you end up getting rheumatic fever. Campylobacter jejuni, remember we talked about the stearic acid component. So this stearic acid component and also the lipooligosaccharide, these will induce formation of autoantibodies. These autoantibodies will damage the myelin sheath, causing demyelination. And this progressive demyelination results into Guillain-Barré syndrome, which presents as a weakness in muscles and nerves. E. coli, if someone gets E. coli, antibodies against E. coli might end up inducing primary biliary cirrhosis. So these individuals will end up with damage to their biliary tree, and then someone will end up getting jaundice. Chlamydia trachomatis and Shigella species, these will induce production of antibodies which are going to be deposited in the eye, in the urethra, and in the joints, which will present as Reiter's syndrome. Yersinia enterocolitica has been associated with Graves' disease because these individuals will have antibodies against cytoglobulins, and then you end up with the abnormal production of T3 and T4, which will present as Graves' disease. Borrelia burgdorferi, this is associated with Lyme arthritis. So you can say that exposure to organisms is actually more linked to autoimmune conditions than even having genetic predisposition. So our genetics will play a role, but exposure to organisms is a very, very important factor. Hashimoto's thyroiditis is associated with the presence of thyroglobulins. Insulin-dependent diabetes mellitus is associated with the presence of autoantibodies against the islets of Langerhans. Addison's disease, we know that one occurs if someone has autoantibodies against the adrenal cortex. Acute glomerulonephritis occurs if someone has autoantibodies against the basement membrane. This is very common in people who have hepatitis B. Periarteritis nodosa is very important in forming small and medium-sized vessels. This is also very common in people who have hepatitis B. Guillain-Barré syndrome, we said this Here we have antibodies against the myelin protein. Wegener's granulomatous normal occurs if someone has antibodies against cytoplasmic enzymes. So we find that the moment you have antibodies against any component of a cell, you can end up getting an autoimmune disease. And this is what we're looking at, that we have this genetic susceptibility. This will only give you linkage. Okay, you have presence of these MHC proteins that make you susceptible, and you end up with failure of tolerances. So your body is unable to remove those autoreactive cells. And in the presence of an environmental factor, these autoreactive cells will end up attacking our own cells, causing autoimmunity. How do you treat these autoimmune disorders? Now, treatment, as you can imagine, will depend on the disease, okay? But by and large, the aim of treatment is to suppress the immune response. So we tend to look at the autoimmune condition, but we aim at suppressing the immune response. So sometimes we can reduce the patient's immune response by giving corticosteroids, okay? We can also give antimetabolites. I think in your pharmacology, you've heard about the drug called azathioprine. This drug is an antimetabolite, which is converted to 6 monophosphate, and it inhibits synthesis of DNA, RNA, and even proteins. And in so doing, it interferes with cell metabolism. It also inhibits mitosis. So we normally tend to give it in patients who have rheumatoid arthritis and also those who have SLE. Methotrexate is also an important antimetabolite. This one inhibits the hydrofolate reductase production, and it will inhibit both purines and thymidic acid production. Okay, so in the end, it interferes with DNA synthesis, and it's very important in inhibiting rapid proliferation of epithelial cells. And because of this, we tend to use it in patients who have psoriasis. So psoriasis occurs if someone is unable to remove excess cells from their skin. So you end up with hyperkeratosis. Okay, so this hyperkeratotic condition will be treated by giving a drug that reduces cellular proliferation. Okay, but you can also give cell-sparing agents like cyclosporine. This should be cyclosporine, not cycloserine, because cycloserine is an antibiotic. This should be cyclosporine. We can give tacrolimus. So cyclosporine is a calcineurin inhibitor. I think if you can remember how macrophages work, they use calcineurin receptor. So this cyclosporine is a calcineurin inhibitor. So it suppresses cellular and humoral immunity, and this normally suppresses the T cells. We can also give these individuals tacrolimus. Tacrolimus acts like cyclosporine because they are both calcineurin inhibitors. Now, sometimes we can also be forced to block the tumor necrotic factor. So one of the most important aspects through which autoimmunity works is by inducing excess amounts of tumor necrotic factor. So you can reduce this production of TNF by either giving an antibody to TNF. One of the most important antibodies currently used is called infliximab, or we can give a soluble receptor to the tumor necrotic factor. This is the so-called etanercept. The downside to this is that these drugs are extremely expensive. A dose goes for over 3 million, and yet someone needs a number of these doses. Okay, Like some of our patients who have very bad rheumatoid arthritis are usually given a infliximab, but you need about 2.5 million every 3 months. And there are very few Ugandans who can afford some of these amounts. We can also do plasmapheresis. In plasmapheresis, we literally exchange plasma. So you get a patient's plasma, basically wash the cells, okay? Wash the cells and put in new plasma. In so doing, you're reducing the concentration of the auto antibodies. This is done especially for patients who have Guillain-Barré syndrome and also those who have myasthenia gravis. Of course, for myasthenia gravis, we can also give pyridoxine and also physiostigmine because they are readily available as opposed to plasmapheresis. But otherwise, if for instance someone has insulin-dependent diabetes mellitus, then you're going to give them insulin. If someone has Graves' disease, then you're going to reduce production of T3 and T4. So we can give them carbimazole. If they are pregnant, we can give PTU, the prothiouracil. So it really depends on what type of autoimmune disorder someone has. Okay, so we treat patients depending on what type of autoimmune disorder they have. Okay, but otherwise, these autoimmune disorders are very, very common. And if they're not managed early, they can end up causing death of our patients. Okay, so that marks the end of our lecture. Do we have any questions? So can we have some questions? Okay, any questions?
Excuse me, doctor.
Yes, please.
Thank you for the wonderful presentation. About the microbial bacterial infections that cause autoimmunity.
Yes.
I wanted to know, is there any autoimmune disorder associated with the other infection caused by T. pallidum? Because I read somewhere that the antibodies formed against T. pallidum can attack cardiolipin, which is a lipid.
Yes, yes. So usually those patients who suffer from Treponema pallidum, they don't necessarily get autoimmunity. So theirs is more of a granulomatous reaction that ends up destroying tissues. So their autoimmune disorder is mostly because of the death of the Treponema pallidum when you start treatment. It is something that happens when patients are given treatment when they have repulse. Okay? So the autoimmunity in this case is induced by the dying Treponema pallidum. Okay?
Okay, thank you, Doc.
You're welcome. Any other question? Okay.
Excuse me, doctor.
Yes, please.
About autoimmune diseases.
Yes,
are there any that are
may be caused by macrophages or those phagocytic cells?
Actually, autoimmune diseases by pathogenesis, okay? When you look at how the destruction occurs, it is because of the macrophages. That is why you normally tend to give steroids, because these steroids will prevent two things. One, they'll prevent mitosis, and also they'll prevent chemotaxis to the site of inflammation. So it is the macrophages that induce excess amounts of tumor necrotic factor. So macrophages play a very, very big role in autoimmunity. Is that understood?
Yeah, it is understood, but maybe on that very note,
Yes.
Can they maybe somehow
Can?
the macrophages themselves,
Can they do what?
in case they misbehaved?
Yes.
We see that maybe they cause the autoimmune diseases. So isn't there any way the body tries to regulate them so they do not cause an autoimmune disease? Because in your presentation, you're talking about only the T lymphocytes.
Okay, so you see, macrophages as macrophages require help to be able to be activated. You understand? So this help comes in from the B and the T cells. If you remember, the innate system and the adaptive system are linked. So the moment you have absence of this communication between the B, T, and the innate, then the innate will not necessarily cause a destruction. So macrophages per se, in the absence of autoreactive T cells and the B cells, will not cause autoimmunity. Okay?
I get you now. Thank you.
Yeah, you're welcome.
Excuse me, doctor.
Yes, please.
Thank you for the lecture. My question is about, selection during the process of development of T cells, the secondary selection. Can that also be a form of tolerance?
The peripheral selection.
The secondary selection.
Yes, that is a so-called secondary, that is a so-called peripheral. It's a so-called secondary selection.
Okay, thank you.
Yeah. So the primary selection is what we call a central tolerance. Then the secondary is the peripheral tolerance.
Okay, because during that process of development, there is a part where they talk about positive selection, then negative selection.
Yes.
Yeah.
So positive selection means that a cell is retained. You understand? So if, for instance, a cell does not react to the self-antigens. So if you look at the central tolerance, the thymus has a number of antigens, okay? And these antigens are complex to the self-MHC, and they are presented to these developing T cells. So if the developing T cell does not react to this antigen, then that one is positively selected. So it means it is retained. So positive selection means retention, okay? But if it reacts, then it is negatively selected. It means it is deleted. You understand?
Yes, doctor.
Yeah. So if this occurs in the thymus and in the bone marrow, that is what we call central tolerance or primary tolerance or primary selection. Then if it occurs in the periphery, then that is the so-called peripheral tolerance or secondary tolerance, which has 3 different mechanisms. That's what I was saying here about the clonal deletion, okay, where you kill, the clonal energy, where you make these cells unable to respond, and then the suppression by T cells.
Thank you, doctor.
You're welcome. So I am going to give you some guideline questions. Please just get a paper and write this down, okay?
Yes.
Do you have a pen and paper?
Yes, we have them.
Okay. So the first question is, explain the difference between central and peripheral immune tolerance. Explain the difference between central and peripheral immune tolerance. Explain the difference between central and peripheral immune tolerance. That's number one. Number two is briefly describe the processes involved in the activation of central tolerance. Briefly describe the processes involved in the activation of central tolerance. Remember, we talked about central tolerance, we talked about presentation of thymic antigens complexing with the self MHC, and then the addition of self-reactive T cells. So number three, discuss the three mechanisms. Discuss the three mechanisms. Discuss the three mechanisms that ensure. Discuss the three mechanisms that ensure a successful peripheral tolerance. Discuss the three mechanisms that ensure that there is a successful peripheral tolerance. Discuss the three mechanisms that ensure that there is a successful peripheral immune tolerance. Number four, how does immune or antigen mimicry induce autoimmunity? How does antigen mimicry induce autoimmunity? Give examples where necessary. How does antigen or immune mimicry induce autoimmunity? Give examples where necessary. Then number five, discuss the factors that predispose to autoimmunity. Discuss factors that predispose to autoimmunity. Discuss factors that predispose to autoimmunity. Number six. Number six. This is a phrase, so you put open brackets. Gender at birth can predispose to autoimmunity. Gender at birth can predispose to autoimmunity. Gender at birth can predispose to autoimmunity. Using examples, qualify the statement above. So inverted commas, gender at birth can predispose to autoimmunity. Using examples, qualify the statement above. In other words, how does one's gender predispose them to autoimmunity? So this question requires you to remember the different aspects of gender that can predispose. So in other words, which MHC
on the question.
found in females. Pardon?
Pardon, on number 6.
Number 6.
Yes.
Gender at birth can predispose to autoimmunity. Gender at birth can predispose to autoimmunity. Using examples, qualify the statement above. So this statement requires you to remember the different MHC class 1 and class 2, and the MHC class 2 diseases that we find in females, and the MHC class 1 that we find in males. Okay. Then number 7 is to list 5 organisms associated with associated with autoimmune disorders. List 5 organisms associated with autoimmune disorders. List 5 organisms associated with autoimmune disorders together with their associated autoimmune diseases. List 5 organisms associated with autoimmune disorders together with their associated autoimmune diseases. And then finally, discuss the role of autoimmunity in transplant rejection. Discuss the role of autoimmunity in transplant rejection. So I think you did transplant, didn't you?
We did. Yes, we did.
So if you did, please ensure that you remember those drugs, because the same drugs we use for autoimmune conditions are the same drugs we use for transplant. So you must know the drug and its mechanism of action. It's a very common question, okay? Autoimmunity and transplant are very, very common questions. So ensure that you remember transplant medicine and also autoimmune medicine. Okay, so if there are no other questions, then I suggest that we stop here, okay?
Thank you, Doctor, especially for the questions.
So please ensure that you attempt those questions, because you're going to find them somewhere. And
Are we supposed to hand in?
Yeah? No, you don't hand in. Just ensure that you can answer those questions, okay? Okay, so please stay safe. See you soon, because I'm sure that we are starting physical classes soon. And ensure that you get vaccinated, okay?
Okay, thank you.
You're welcome.
Vaccines to be vaccinated. Group.